out for us to enlarge our scope of reaching the public and our own doctors, especially on mental health issues actually. So we must appreciate and thank the Vijay team for being with us today. And of course, the credit goes to Dr. Dhananta Bettu for roping them on the last moment. I remember the day when morning I saw that some flyers were circulated in the group, and I had noticed that we didn't do anything. And we know that it's an issue, major issue, where day in and day out people dying because of suicidal attempts, whatever it is actually. And I also remember same day one, what is that? Malaika Arora's father committed suicide. That was a news in the actually one of the TV channel. So I thought maybe it's high time we must reach out to our people, especially doctors are at high risk of having stress-related issues, and of course they are not separated from the risk of the suicide and related issues compared to the public. So we thought we must take up. That's why we decided to go with that, and we are very thankful for being with us, all of us today. And let me start today's meeting as per the IMA policy. We're going to start with IMA prayer. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಲಿ. ಜೈ ಹಿಂದ್, IMA ಜುರೇಯವಾಗಲಿ. With this, I would like to welcome everybody once again, and I'll request our president to welcome again and give introductory speech, and we'll proceed with that. Thanks so much.
Thank you, Karnakar. Yellarigu namaskara. Actually, Vijay idare. So Harish Dhananta Bettu idare. Rajendra Prasad is there, and Veena Bhatt I am seeing, Kulkarni, and so many good friends are I am seeing here, and definitely it is very, very important topic actually. ನಾನು ಯಾಕೆ ಇಂಪಾರ್ಟೆಂಟ್ ಟಾಪಿಕ್ ಅಂತ ಹೇಳ್ತಾ ಇದ್ದೀನಿ ಅಂದ್ರೆ, ನಾನು MBBS ಜಾಯ್ನ್ ಆಗಿ 1980 ನಮ್ಮ ಕ್ಲಾಸ್ಮೇಟ್ ಒಬ್ರು ಸೂಸೈಡ್ ಮಾಡ್ಕೊಂಡ್ರು. ಸೊ ಈಸ್ ಫ್ರಮ್ ತುಮಕೂರು ಟಿಪ್ಟೂರ್ ಏರಿಯಾ ಆಕ್ಚುಲಿ. ಸೊ ಅಲ್ಲಿಂದ ಫಸ್ಟ್ ಸ್ಟಾರ್ಟ್ ಆಯ್ತಲ್ಲ. ಆಮೇಲೆ ಆಸ್ ದಿಸ್ ಒನ್ ನಮ್ ಕೋವಿಡ್ ಟೈಮ್ ಅಲ್ಲಿ ಎಲ್ಲರಿಗೂ ಗೊತ್ತಿರೋದು ನಾಗೇಂದ್ರ ಅಂತ ಒಬ್ರು TH. So he has committed suicide because of the pressures and all. Aವಾಗ actually so many aspects we have discussed all these aspects, and ಇದ್ರ ಬಗ್ಗೆ ನಾವು ಸೈಕ್ಯಾಟ್ರಿಸ್ಟ್ ಎಲ್ಲ ನಮ್ಮ ಅವಾಗ ಪ್ರೆಸಿಡೆಂಟ್ ನಮ್ಮ ಮಧುಸೂದನ್ ಕಾರಿಂಗೂರ್ ಇದ್ರು. ಅವ್ರಿಗೆ ಸ್ವಲ್ಪ ಇಂಟಿಮೆಸಿ ಟುವರ್ಡ್ಸ್ ನಿಮ್ಯಾಸ್ ಜಾಸ್ತಿ ಇದ್ರು. ಹೋಗಿ ನಾವು ಮೀಟ್ ಮಾಡಿ ಕೊನೆಗೆ ಅವರು ಈ ಓನ್ಲಿ ಗಾಟ್ ಅಪ್ರೂವಲ್ ಅದ್ ಮಾಡಿ ಅದಕ್ಕೆ ಒಂದು ಬೇರೆ ಒಂದು ಸಿಸ್ಟಮ್ ಮಾಡೋಣ. ಸೊ ದಟ್ ಸೊ ಲೆಟ್ ದೆಮ್ ಟ್ರೈನ್ ಆಲ್ ದ ಡಾಕ್ಟರ್ಸ್ ಅಂತ lot of work he has done. See, I have to, it is my duty to whatever it is happened to tell. It is a thing happened during the COVID time. So many has undergone depression, all this aspect. Now adella ಮಾಡ್ಬಿಟ್ಟು ಇದಕ್ಕೆ ಒಂದು ಟ್ರೈನ್ ಅಪ್ ಕೊಡೋಣ ಅಂತ ಇದ್ರ ಬಗ್ಗೆ lot of discussions were happening, especially suicide ಎಲ್ಲ. Recently ನಮ್ಗೆ ಎಲ್ಲರಿಗೂ ಗೊತ್ತಿದೆ, ಇಲ್ಲಿ MBJ ಕಾಲೇಜ್ PG student she has committed suicide. Our ನಮ್ಮ pediatric PG ಒಬ್ರಂಗೆ he has committed suicide last year. So many aspects. ಆವಾಗ ನಮ್ಮ ಶುಭ್ರತಾ, she is the one MSN ನಮ್ಮ ಇದಕ್ಕೆ from Shimoga side. She started ಅದೊಂದು ಸ್ಟಡಿ ಎಲ್ಲ ಸ್ಟಾರ್ಟ್ ಮಾಡೋಣ. ಸೊ ಆನ್ಲೈನ್ ಎಲ್ಲಾ PGs ಕೊಟ್ಬಿಟ್ಟು ವಿಲ್ ಟೇಕ್ ದ ಒಪಿನಿಯನ್ ಅಂದಂತೂ ಸ್ಟಾರ್ಟ್ ಆಯ್ತು. ನಮ್ಮ ಇಂಡಿಯನ್ ಮೆಡಿಕಲ್ ಅಸೋಸಿಯೇಷನ್ ಆಲ್ ದಿಸ್ ಟೈಪ್ ಆಫ್ ವರ್ಕ್ಸ್ ವಿ ಆರ್ ಡೂಯಿಂಗ್. ಐ ಆಮ್ ವೆರಿ ಹ್ಯಾಪಿ ದಟ್ ಸೋ ಮೆನಿ ಇಂಟ್ರೆಸ್ಟೆಡ್ ನಮ್ಮ ಟೀಮ್ ಆರ್ ದೇರ್, ಎಸ್ಪೆಷಲಿ ನಮ್ಮ ಇಂಡಿಯನ್ ಮೆಡಿಕಲ್ ಅಸೋಸಿಯೇಷನ್. So I think yesterday ನಮ್ಮ Karnakar secretary told about that. Why can't we have sir ಅಂತ. Why not? Definitely we'll have ಅಂತ ಹೇಳಿದೆ. But I'm little surprised that so early he made it good. So definitely it is a very good especially thing happened. So I'm very, very happy. Good speakers are there. So definitely they are there. And Dr. Bichal. So we are going to meet in Raichur. So I have to congratulate him once again also for getting our award also. Definitely. And so without much wasting time, so definitely I'll request the concerned people to go ahead with the program. Thank you for arranging all this aspect once again. And,
thank you sir. Thank you, President sir. Before handing over to Bijal, shall I have a privilege of introducing Dr. Bijal sir?
Please.
Bijal
please.
sir is a president of Indian Psychiatry Society Karnataka chapter. He is a very dynamic personality. He studied from NIMANS, Bangalore. Presently, he is the professor and head of the department from Department of Psychiatry at
Gadag
Gadag
Institute.
Institute of Medical Sciences. So he is in a government setup. He has done wonders in the field of psychiatry, especially in the government setup. And he is also a very good teacher. He is a very dynamic. He was a very dynamic secretary. I remember he has done a lot of things, good things to IPSKC. IPSKC is a very prestigious institute. It won about the best national award 9 times. It's a very reputed Karnataka state branch in the country. So he got that particular post on this occasion, and he is also a very good teacher. And rightly he is awarded Best Teachers Award this time by Ima Ksb. We congratulate him. Sir, we expect much from you as a president of Indian Psychiatry Society Karnataka chapter, and he extended wholeheartedly his support to Ima Ksb this time, and we expect such support in future too. So, with these few words, I invite Dr. Bijal sir to take over the stage. Thank you.
No, I have to invite Dr. Supriya Hegde also. I forget. And sorry, madam.
So thank you.
Yeah.
Okay.
I think chairperson will do all those things.
Okay.
Thank you.
Okay.
Thank you.
Thank you very much, sir. Indeed, I am very much thankful to two of my seniors, Dr. Srinivas, who is the IMA president, as well as Dr. Karunakar, who is also my senior in our Bellary Medical College. Thank you very much, sir. In front of you, I am still I am your junior only. So at the outset, I thank IMA Karnataka State Branch to coordinate to have an association with IMA Indian Psychiatry Society Karnataka State Chapter. Actually, when Madhusudan was there, he was my classmate. So it was a COVID time when I was a secretary, and actually Dr. Arisha Delanthapattu, only our past president, he has initiated that program. So after so many deaths have happened among the many people, and also among the medical fraternity and medical health professionals. So what we thought was, we started along with NIMANS. So during Dr. Venkatachalapati time, we started an IMA helpline for only for the IMA doctors during the COVID time. And almost nearly we have received around 800 calls, as I remember, from the IMA people, which were kept confidential. They were in stress at that time. So that was not only IMA Karnataka, it is across India. We received around 800 plus calls. That was one thing I want to do. And also after that successful that thing, we also initiated a program called as the paid series. That is the PAID, Psychiatry Academics for IMA Doctors. So we did around 12 sessions during that time, along with the help of the NIMANS faculty, Dr. Naveen, Dr. Manjunath, Dr. B.M. Suresh, and many others. So with an intention of imparting the basic psychiatric knowledge to various special branches of the medicine faculties, so that they can identify at the primary care level the common mental disorders, and they can start treating them at the earliest. That was aim was there. So today, as all of you know, and Dr. Arisha Delanthapattu pointed out, as soon as I became taken charge of the president of IPSKC. So once again, I thought I have to request IMA president, current president, actually, with respect to having a in-person one every month in all the local branches. If you write a letter to the local branches to call up one of the psychiatrists, so that we can give a basic primary care management of the common psychiatric disorders which they come across. Because see, 30 to 40% of the patients, what a general physician sees or any specialty person sees, they have one or the other psychiatric components in that. So they may require psychiatric medication or non-pharmacological method of treatment, which can be given by the primary care physicians like IMA doctors across this thing, so that we can reduce the mental health gap, because almost 80% mental health gap still exists across India. That is one. So in this respect, I request the IMA president to have an MOU with IPSKC, so that we can go to the branches across state and give this. And as
Done,
you
sir.
know, yeah, as you know, every 40th second, one person is committing suicide, and every 1 hour, one in India, one student is committing suicide. So if you look at that scenario, the huge burden is so much, and there are various reasons for suicide attempts or suicide this thing. And most of the times, what happens is when people come with a deliberate self harm, they first approach the primary care physicians or emergency doctors. So where still there are significant changes have occurred in the law, but still people don't want to tell that they made a suicidal attempt for various reasons. Just because there is a stigma is associated, number one. Second one is the fear of the law, because people still think that they lodge a criminal case against us, which was there at section 309 as per the Indian previous IPC, which was carrying 1 year imprisonment and 2,000 rupees fine. But actually, that has been taken out around 5 to 6 years back only, which has been decriminalized. So still, many physicians are not referring such DSH cases because it has found that around 70 to 80% of the people who commit suicide, they have one or the other mental health issues which are contributing to their suicidal attempt. So in this aspect, recently we have celebrated World Suicide Prevention Day. Every 3 years, WHO and World Federation of the International Association for Suicide Prevention give a triennial a theme for this activity. This year, changing narratives on the suicide. That this is the theme for next 3 years with start conversation, because many people doesn't talk about the suicide or death wishes. So in this, and there are many myths and misconceptions are associated with suicide. In this aspect, we need to impart the mental health awareness, especially with respect to the prevention of suicide among ourselves first. That is a health professionals. Today, we have two eminent speakers who are my colleagues. One is Dr. Guru S. Gowda, who has done significant work in suicide along with Dr. Senthil Kumar Reddy and Dr. Krishna Prasad at NIMHANS. Dr. Guru S. Gowda is the associate professor in the Department of Psychiatry, and he also heads the one of the faculty in the forensic psychiatry unit also. So I welcome Dr. Guru S. Gowda on behalf of Ima Ksb as well as the IPSKC for this program, and who will be talking about the current scenario of the suicides in India, epidemiology, and various other factors. And we also have with us another our IPSKC member, Dr. Supriya Hegde Arur. Madam is the professor and head at the Department of Psychiatry at Father Muller Medical College at Mangalore. Madam has a very vast experiences. She has done tremendous work in the women's mental health issues and also among the child and adolescent psychiatry. We welcome you, madam, again on behalf of IPSKC as well as IMA KSB. So,
Thank you,
madam
sir.
will be talking preventive measures, how preventive measures has been taken to curb this high prevalence of suicide among various populations. So, I request Guru Gowda to initiate, then madam will take over. Over to Guru.
So first of all, I'm audible.
Yes, sir. Go ahead, sir.
So I would like to thank Indian Medical Association Karnataka branch as well as Indian Psychiatric Society Karnataka chapter for giving this opportunity to talk about epidemiology and risk factor of suicides in India. As Dr. Bijal is pointing out, it's a very important issue discussing narratives, changing narratives about suicides in the global context and why it's important and what's our role. So it's a multi-stakeholder responsibility. We need to know what we can able to contribute to society back in order to prevent suicide and what we can able to do. In the with this outset, I would just talks about what are the terminology we usually use in terms of discussing about suicide. So broadly, many of times we use different suicide, successful suicide, incomplete suicide, non-suicidal self-injury, deliberate self-harm, suicidal intent, suicidal death wishes. So probably these are all quite interchangeably used, and these have nuances. At least when we start using these words correctly, appropriately, with judiciously, we can also account what we are discussing about. So first of all, and what we want to talks about is what do you mean by a suicidality is. It's a spectrum of thought, behavior, or tendency related to suicide. So it ranges from death wishes, suicidal intent, deliberate self-harm, suicide, and non-suicidal self-injurious behavior. Before we go into and these things, so these are the spectrum. So any person can have a spectrum of issues in the range of suicidality in terms of death wishes, where a persons have a thought of contemplating to end his life, where he never planned it, there is no action behind that, where in that stage we say person having a death wishes. It may be more of a passive nature, it may be of active nature, whereas there is stronger inclination with a plan to carry out, like I would like to carry out an suicidal attempt in a plan A, plan B, plan C, then we say he has a suicidal intent. Whereas in terms to other concept, what we need to understand is sometimes because of extreme level of distress, people can also make self-inflicted injuries on the bodies without any clear intent to end their lives, where such sort of, we say, more of non-suicidal self-injurious behavior. So, or also sometimes we also say it's a deliberate self-harm behavior. Whereas suicide, we talks about where the individual inflict to harm themselves with the intention to end the life. Where we talk about suicidal attempt, where the intention behind the act is to end the life. However, they may not be successful. It become an incomplete suicide. Where completed suicide, where it talks about where he attempted suicide, he intent to end the life and it becomes successful. So we use these terminologies in and out, and I think sometimes we get a referral with a patient is suicidal. So sometimes maybe a little bit stigmatizing, better to use patient having a thoughts of ending his life or death wish, suicidal intent. That also gives us some idea what can be done for that. So also we need to understand suicide is a complex problem for which there is no single cause. Sometimes we also see monocausality hypothesis, where they say individual attempt because of example, or individual attempt of financial problem, individual attempted suicide because of love failure. Most of the times when we dissect these issues, we are able to find only in a more of an event happen near to the attempt, not we understanding the person as a whole. That person may have suffering from coexisting mental health issues, may have coexisting substance use issue, he may have already had coexisting lot of social support issues. So maybe in a interim, the more of coincidentally, and something happened near to the attempt, we just try to label the issues, and because of that. However, you need to understand suicide in a more complex manner from the holistic perspective than just labeling with a single hypothetical causes. So we also need to understand that why certain people make decision to end their life, but however in most of them not, and some situation, even the situation is much worse, people not going to attempt. So that talks about that individual upbringing, his temperamental styles, and his support system, how the individual able to cope with the problem, individual is not able to cope with the problem. So it's not about an outside societal problems or the external reasons, only a results of suicide. However, lot of internal family, social driven factors also play important role in shaping suicidal attempts and behavior. What we need to understand that most suicides can be prevented, even though we are not able to identify why he attempted 2 days back, he was fine, he attempted today. So however, we need to understand as a person as a whole, we can able to provide some sort of prevention strategy, how we can able to help to reduce the suicidal rate. As Dr. Bijal is pointing out, the global suicide statistics talks about more than 7,20,000 people die due to suicide every year. Almost nearly around 20 times more suicidal attempts happens. Almost you need to double 7,22 into and 20 times. That's the rate of suicidal attempts happening in the community. In perspective further, and low and middle income countries accounts for at least a 3/4 of total suicides in the worldwide, as well as the most youngest population of the world, that is 15 to 39 youths, are account 1/3 of total suicides. Coming to an National Crime Report Bureau data, suicides in India, as for recent 2022 data talks about the total suicides happened in the year of 2022 is 1,70,924. It almost equals to 12.4 per lakh population. And if you dissect further, it almost that 71.8% men committed suicide, whereas 28.2% women committed suicide. However, if you look at little bit larger perspective, women's likely to make more attempts, whereas men likely to make completed attempts. So attempts are more common of less lethal natures in women, whereas more lethal completed attempts, complete suicides are more common in men's. But if you look at as a country as a larger perspective, there are states where suicides rates are very, very high. Compared to the national data rates around 12.4%, where Sikkim, Puducherry, Chhattisgarh, and Andaman has a highest rate of suicide, which ranges from 43.1% to 29.7%. Are we in average with the nation? No. In Karnataka as well, suicide rates are pretty much high. It's accounts 20.2%, which is higher than the national rate. It could be because of financial distress as well as ongoing agriculture issues in certain part of the state. If you look at trend of suicide, it also need to understand, are we looking at data in a more of cross-sectional manner, or things we need to look at longitudinally? If you look at data in a longitudinal manner, over last 5 years, nearly 27.07% are increased rate of suicides, whereas 2018 almost rate of suicides are 10 per lakh. Recently in 22 it's around 12.4 per lakh. So it suggests that the rate of suicides in the country is growing. However, what we are getting the data is from the National Crime Report Bureau data. Even though there are certain place, the reporting is also not happening in the manner what is expected, because of lot of systems are not in place. So even though what we're seeing is a maybe iceberg of data than the real picture what is happening in the country. If you look at further, looking at do these differences are limited. For if you look at in a mega cities like in a Bangalore, Chennai, Delhi, the rate of suicides are pretty much higher, and which is also increasing, maybe because of rapid urbanization and also because of migration. The rate of suicides in a mega city is almost 16.4 compared to national average of 12.4 per lakh. And this is a data talks about metropolitan cities data on how number of suicides are happening. And also looking at urban versus rural trend, definitely the increased trend of suicides happening in the rural context over last few years. The age-wise, especially like young youths contribute to major proportion of the suicides in the country compared to the age group around 45 to 60 onwards. If you look at, this is from the National Crime Report Bureau data. However, Lancet Public Health also worked on Global Burden of Disease study of 1990 to 2016, where looked at gender difference and state variation in suicides in India. It talks about that India accounts for 18% of the world population, whereas 42% of the population aged 15 to 39 years. Indian contribution to the global suicide is almost 1 in 3, 1 of 3 women, 1 of 4 in men. Men to women ratio is almost 1.34. The leading cause of death in India in age 20 to 39 years is maternal mortality among women, followed by suicide, RTA among men, followed by suicide. So suicide rates were higher in India than the global average, what we can able to infer from the old data. So you got to look at the young population, youth suicides in India. India reports one of the highest rate of suicide globally. In the age group of 15 to 29, almost it accounts for 34% of the total suicides in India. As well as common pressure, they are identified like an academic pressure, unemployment, relationship issues, mental health issues like substance use, and also some sort of gender disparity were noted. Male die because of suicide, female in this age group have a higher rate of suicidal ideation and attempt than the completed suicide. So what data talks about what sort of method they're using? In India, most common methods were hanging, followed by poisoning and drowning, also jumping. There are other means of use like overdoses of medicine and sort of that. However, hanging and poisoning and drowning are the commonest method of suicidal methods in as per NCRB. However, firearm self-harm immolation is one of the important method in the Western countries, which is probably India does not have an access to these sort of ammunitions and license. Hence, probably hanging become more common method compared to the worldwide. So when they looked into data specific to the what are the reason behind the suicides in India, as per the FIR copies and other thing, they noted that most commonly a family problem, where accounts for the 31.7%. Second important cause is illness. Illness related deaths are suicides are more common. When we went a little bit down into what sort of illness which are associated with more of suicides subsequent to that, individual suffering from illnesses such as tuberculosis, which require long-term treatment, and drug-resistant tuberculosis, or if they have something like combination of multimorbidity, HIV in combination with tuberculosis, or individuals suffering from cancer, individuals suffering from chronic pain-related conditions are the common causes for illness-related suicides in India, as well as another important issue they are noted is drug abuse and alcohol addictions, which accounts for nearly 7%. As we know, alcohol being a more of legally approved substance to use, it causing such a 7%, it accounts for the overall suicide-related mortality in India. Other issues like unemployment, professional issues, failure in examination, property dispute, love affair also contribute to the reasonable extent for the completed suicide-related death in India. So it's also need to understand what could be the important risk factors which cause suicides in India across the lifespan. There are certain things we need to understand. There are certain risk factor which is age specific. There are certain risk factor which is present. It can be more important throughout the lifespan. For example, talking about depression, family history of suicide, past history of suicidal attempt, presence of community-wide discrimination, gender-based discrimination, absence of social support, financial insecurity, stress in the family. These can happen to individual any point of the life, which can be important risk factor for individual to attempt suicide. So probably working on those lines can be important factor across the lifespan to prevent suicides. However, there are issues which can happen to specific age group. For example, academic failure, disruption in education. So school refusal, not going for a school, an important risk factor, and also failing the exam, also an important issues, especially in childhood. Whereas intergenerational conflict, there's it happening some conflict issues in the generational pattern. There can be a problem across the lifespan, maybe in childhood, adolescent, adult, maybe like that, as well as abuse, maybe of emotional, physical, sexual abuse especially maybe issues with respect to childhood and adolescence related suicide. However, bullying, stigma, minority stress, trauma are more important issues with childhood and adolescent risk factors. Whereas in adults, important things are early or arranged marriage, marital conflict, domestic violence, as well as interpersonal violence, substance misuse, sexual violences are important thing. Addition to that, if they also have and social isolation, grief, discrimination, loneliness can also affect important risk factors of suicides in adult. Whereas older adults and discrimination, social isolation, elder abuse, and loss of loneliness are the important grief are the important risk factor for elderly associated risk factor for a suicide. So these factors interact in a fashion of a lot of intersection will be there. These vulnerabilities and risk factors can determine the suicidal risk for individuals. So as we discussed, these are the important risk factor for suicide. And also we need to understand about like some concept called influence of significant people. Like for example, an celebrity or an affair in the school or in the family members who have died by suicide, that can be a model. Sometimes this can be represented by media in a very glorified manner with a more of sensationalism, more of glamorizing the issue, that sometimes this modeling can also cause suicide among the more vulnerable children's, adolescent, adult who also going through similar sort of stress and difficulties. So if say my model, my known person completed suicide who also had the same problem, I am also having a similar sort of problem. Hence, I think that may be the solution for the problem. Then that can also result in a more of cluster suicide happening in a very short period of time in terms of more in number than the expected fashion. So this is called in a Werther effect. Sometimes the attempting the suicide or using the methodology same, it can the copy the method, it's called a copycat suicide. However, this is quite important issue, probably like how we need to sensitize the media as well as the schools and public, especially about reporting and discussing about suicidal attempts and picturizing them, sensationalizing them, what are the things should be done. With respect to probably like Press Council of India come up with an guidelines. What are the guidelines should be used in order to report a suicide in the newspaper. Similarly, certain culture, certain religious beliefs allow suicide. For example, nirvana concepts in some this thing they usually allows of not having food for a certain period of time, then ending the life, as well as certain cultural belief. For example, in the communities where culture suicide considered as a more of a sin. So a lot of cultural and religious factor also play important role as a risk factor for a suicide. Addition to that, we only know what are the things which can vulnerable for a suicide. However, there are certain things which also protect against suicide. These are adaptability. Probably individual has a quite good adaptability skill to the upcoming problem, situation, वगैरह. So then probably an individual can able to cope the issues and deal with the problem. That can be important factor. And individual has a good self-esteem. Individual has a sense of meaning or purpose in life, like he want to achieve certain things and he considers this is the meaning of his life. So then such sort of people are more protective against the ongoing stressors, life events, so that they can able to cope with that. Similarly, if they have an problem solving life skill issue, then they're able to cope the problem well, they can able to deal that. Addition to that, if individual connected well with the community and with the interpersonally with other family members, then it becomes an important protective factor against suicide. Similarly, a cultural, religious, and personal belief that discourage suicide also considered as an important cultural religious factor prevent as a protective factor against suicide. So the couple of the recent amendments happened, the recent act came into picture in context of suicidal treatment, which most of us may not aware about. That is about IPC section 309. Initially, any suicidal attempt has to be considered as a criminal act, where, as Dr. Bijal is pointing out, it has a 1 year of imprisonment with a certain amount of fine whoever attempted in their life. Now that non-penalization is an attempt what they made in MHCA, where it prohibits the criminalization of suicidal attempt, recognize them, it may be a manifestation of underlying mental health issue rather than the criminal act. So it taken the shift from more of punitive approach to an health-oriented approach. So than punishing with the legal measures, than providing with a more of healthcare oriented, where emphasize about providing a treatment and also about supporting the individual who attempted suicide. So addition to that, also it talks about integration of mental health for the attempted suicide, focusing about appropriate mental health care without criminal penalties. So hence it's quite important that any individual who made either a deliberate self-harm attempt, non-suicidal self-injurious behavior, any sort of the issues, probably like having a mental health screening from the mental health professional like psychiatrist is essential before the discharge plan. So that I think in the couple of places already in place, probably that's an important measure as a medical community we should implement, especially among people who attempted suicide. Thank you. I think Supriya Madam talks about more of suicide preventions and strategies and way forward.
Yeah,
Thank you.
covered so much about epidemiological issues. Let us take the questions all together after Dr. Supriya speaks about the preventive strategies. Over to Dr. Supriya, madam.
Am I audible?
Yes, madam. Yes,
Yeah,
madam.
can somebody
I'm
screen share,
Yes,
please?
I'm sharing.
So I'll be speaking about suicide prevention, strategies, challenges, and path forward. And Dr. Bijal asked me to look at the practical aspects and also touch upon how suicides in our doctor community can be prevented. So next slide. So this is a very important question. Why do people commit suicide? So Dr. Gowda covered that more than family problems account for more than 30% of why people commit suicide, and illness-related factors contribute around 20%, mostly tuberculosis, pain syndromes, cancer, etc., and substance abuse less than 10%. But if you look at the whole scenario in the clinical practice, what we see is many a times it's a clustering of stressors which pushes a person to try and take their own life. Next slide. So the next question practically which comes to the mind is it possible to prevent suicide? As a group, we psychiatrists believe it is possible to prevent suicide. Many people would argue otherwise, that somebody who's destined to die, will take his life anyways. But there have been times where timely intervention has saved lives. So we believe that, of course, it is possible to prevent suicide. The next slide. So what are the strategies for suicide prevention? Next slide. So first thing is we need to identify the people who are at risk for attempting suicide. So vulnerable populations include those who are marginalized, socially deprived, going through severe stress in wake of crisis at life, or it could be even a mishap. And certain personalities are known to attempt more than others. Also, if there is a past history of suicide, that means definitely that is one of the most important risk factors for next attempt. And not just handling attempted suicides at that point of time, but we also need to see how we can prevent further attempts in the future. Next slide. So working at a larger base, if you're looking at community-based suicide prevention, we need to look at establishing effective broad collaborative partnerships to prevent suicides. So Sir was talking about how, there are certain age-specific and certain, things which are risk factors which span across lifespan. So if you look at age-specific thing, if an academic failure can cause a suicide attempt in a child, then resilience building probably would help to prevent such attempts. Or if you are looking at, bullying in adolescence, which can push an adolescent to attempt suicide, then maybe certain aspects of how to prevent bullying, how to, how the school can take part in, preventing these things happening at school especially. And now cyberbullying also is one of the factors. So education, especially imparting education to children and parents also, can help in some ways to tackle this problem. But this is more of a theoretical concept. But if you look at school mental health, a lot of us psychiatrists go to various schools during the PTA meetings, and we do talk about positive parenting. We talk about how to identify children, who are at who may be disturbed because of these things happening around them in their peer group and even at school. Next slide. So I think the next few slides are probably how, we as doctors, we see so many patients, and many times we would be surprised that, this patient just came to me the other day and now he has taken his life. So are we able to pick up the warning signs? Next slide. So what could be the warning signs? So these are signs which herald that probably this guy, there's something wrong with this guy, and maybe he or she may do something to end his life. Next slide. So many elderly, when they come to you, they'll be talking about, what is the use of life, and, and am I becoming a burden to others, and is there any hope for me? And these are the things which normally we will take, oh, he's old and that's why he's talking like that. But actually, that person may be harboring a death wish or a suicidal ideation. And many a times we assume that by asking this question, we will induce those ideas in that patient. That's not true. So you can feel free to ask these difficult questions that, sir, have you been thinking of, life is not worth living? Have you been thinking of ending your life and things like that? So if the person says yes, then definitely you need to mobilize some help to help this individual. Also emotional factors, such if somebody is looking sad all the time, moody all the time, anxious, restless, we need to be very careful and think that maybe there is something wrong. Also, many people, when they are planning to kill themselves, they start writing a will, they give away the most precious possessions, they get affected in terms of sleeping differently, they isolate from others, they start over-medicating with substances. This is something which we see in doctors as well. So if you find that these things are happening around you, these are all red flags. Next slide. So risk factors, Sir has already covered, but I will just talk about it briefly in the next slide. Next slide. There's one more part of the slide, just this one, sir. So if there is a previous history of suicide attempt, definitely means that there is a risk and it should not be taken lightly. Also, if there is a mental illness, there is a family history, there is substance abuse, and the person is known to be impulsive and aggressive, chances are more. Also, if there are other social factors contributing, then risk factor for suicide becomes more. Next slide. So in the next slide, we look at how we decide whether somebody's risk is high or somebody's risk is not so high. So if you look at the top part of the slide, it shows that if somebody has a family history of suicide, but there are strong protective influences, and the person is still hopeful of a good life, then chances are not as much. But if you go down the slide, you will see that if somebody is severely depressed and there's a triggering event and there are no protective influences, and he has made a lethal attempt in the past, and he has been having recurrent thoughts of killing himself, chances are that there is going to be an impending attempt. So in those cases, the action needs to be more prompt, it needs to be more immediate. Next slide. So what immediate attention can be provided? So you are in your clinic and there's a person who says that I want to kill myself, and it's probably the end of the day, your friend psychiatrist might have gone home. So you need to give, to be a good listener. You need to give attention to what the person is saying, and in a very non-judgmental kind of way, just ask how you can help. Many times, even if they say that I do not want to be helped, this is how I want to end my life, you need to start planning as to how you can at least temporarily prevent the attempt at that moment or on that day. Next slide. So we could distract the person by asking him to do things which he likes, or talk to a friend, or you get the number of a friend and call that person and ask that person to stay with that patient. Or you could encourage that patient to do some activities with a family member which should distract the patient. Here it is important to remember that the suicidal thoughts are not a permanent phenomena. They come in waves. So if you ride that wave, then maybe you've actually averted the crisis, at least temporarily. Next slide. Also, like if somebody tells you that I'm suicidal, encourage them to talk to somebody, encourage them not to be alone, encourage them to meet a psychiatrist, to consult a counselor. And there are many suicide helplines. I've just put one, but if you look at the internet, there are different suicide helplines run by different organizations, and many of them work. Next slide. So if my own friend is suicidal, my own family is suicidal, how can I help? And this is not from a psychiatrist angle, this is from any doctor's angle. First is you pay attention, be open-minded, don't ridicule the patient, don't be judgmental, don't say simply, things, insensitive things like, I dare you to show me whether you can do it. But instead, lead them to safety and don't leave them alone. Because if you leave them alone, then maybe the chances of attempt are multiplied. So the next part of the talk is what are the challenges that we are facing. Hello, am I audible?
Yes, ma'am. Yes, ma'am. Continue.
I had some connectivity issue. So the challenges that we faced in managing in suicide prevention is, one is that there is gross underreporting of stats for various reasons. And there's a lot of misrepresentation of suicide in social media. There's a lot of stigma associated with suicide, and general understanding of mental illness itself, even amongst our own brethren, is not as good as we would like it to be. For example, there was a reference for me today, and surprisingly, the family members didn't want me to divulge that I was a psychiatrist. So I would be talking about mental health issues. I'd be talking about why the person is sad, but I would not be a psychiatrist. Then what else would I be? So if you look at the way we look at suicide, we're looking at suicide at a very broad angle. Sir covered issues regarding the epidemiology of suicide, the way it is rising in the prevalence is on the rise, especially in certain vulnerable populations. And I have tried to cover the strategies, challenges. Path forward would be to probably have a more open-minded approach and talk about suicide. The whole theme this year has been to change the narrative on suicide. So instead of adopting an approach which is stigmatizing and which is very, which puts down or discuss about it openly and be more inclusive and lend a non-judgmental ear. So with this, I come towards the end of my presentation, and over to Dr. Bijay.
Hello.
Yes, sir. Audible, sir.
Hey,
Bichel,
madam.
sir.
Yeah. Hello. Hello.
Yes, sir. You're audible, sir.
Okay, thank you, Dr. Supriya. Uh,
Thank you, sir.
that was well covered, this thing. Now, only thing is, as this year's uh, theme speaks about the changing the narratives and start conversation on the regarding suicide. So, one thing you need to think is why people are still not. You are told about the challenges faced, underreporting and all. So, why it has to be people are not coming forward when they make such attempts and not telling. So, those and also stigma associated. And as there are some reports now, psychiatrists among the medical professional, the leading suicide among the specialties, psychiatrist fourth in the rank, and third is second is OBG, and third first one is as usual anesthetist. They commit more. Those people also not coming and reporting, and they are not start talking conversation. At a given moment of time, if somebody is says about that they have death wishes, somebody need to handhold them, and if you give some ears to their stories, definitely you can. One or other suicides. So let us now ask the participant.
Bichel, sir, your voice is breaking.
Voice is breaking.
Yeah. Now you're audible, sir. Yeah.
Yeah. Can participants ask questions? Any queries are there?
Yes, sir. The floor is open. Harisha, sir.
Yeah, the floor is open. Anybody can ask questions.
Sir, can I ask a question? Can you hear me?
Sure.
Sir, I'm Dr. Ashalata Mata. I'm a general practitioner working in Bangalore Whitefield area. In Bangalore, in one of the prestigious engineering colleges, recently, in the last 1 year, I think we have seen three suicides around 17, 18-year-old college students. They've jumped from the 8th floor like that. So that was very disturbing me because one of my son also is studying, in the same engineering college. We felt very sad. And so I know that there is a college counselor, and I did meet her once just when I went there for a parent-teacher meeting. But after that, again, I mean, it has happened. The two more children have died. So in this year, three children have died. So what can, as a doctor and one of the parents, what can I do? Is there any, should we go to the college and approach the college principal saying that we can go do some, give some education? What to do, as a parent and a GP, what can I do?
Guru?
Yes, sir. Actually, it's a very important public health issue that we are seeing in young and adolescent suicide. Probably Indian Council of Medical Research come up with a youth champion program where it's a more of a buddy system. They identify one or two and young child in the college, they can be a champions to identify especially vulnerable adolescents who have these sort of issues. Basically, identification become a more important issues and connect them to a mental health professional. These are the two issues where we can able to help them. So potentially it's important issues, somebody who are volunteer themselves to understand this issue of how to pick up people who have a certain degree of warning signs, as madam pointed out. Probably it's called a gatekeeper training, where usually we train an individual who are interested. It may be a teacher, it may be a parents, it may be a student, or it may be anybody who want to help the community back in terms of identifying who are vulnerable people for a suicide, so that such people, one thing what they can able to do is identify them, talk to them, and connect back to the system wherever the health resources are available. So one of the important health resource which I can talk about is telemanas, where people who are under distress, they can easily talk to that. So Telemanis is a 24/7 available helpline number where people can reach out to that, so that if they have anybody in distress, they can talk and they will provide us some sort of relief. And similarly, there are a lot of helpline numbers where people can reach out to that. For example, if you put that I want to end my life in certain things, suddenly what Google talks about is helpline number. So like that, probably like we need to use the existing resources, map them, connect to back to the society in the healthcare system. That may be the things which as a parent, as a teacher, as a student, they can do, ma'am. Anything
Sir,
else?
one more thing, sir. Like suppose if I mean, obviously that information that there is a training to how to, identify those, vulnerable students. That kind of a training is available. That information is only not available to students or the parents. So how do we tell them that, help is available, and also one of any of the students or the parent or the teachers can become a little bit trained to identify. So how do we do that? I mean, do you think I can go and talk to them and sort of say that this kind of help is available? If anybody is interested, they can train themselves. So
Yes,
we can, I
ma'am.
mean, obviously we can put it in the WhatsApp groups, and or maybe in the college we can inform the mentors. But who will train and where to train? Suppose if myself only, if I want to train myself, so how do I do? What to do?
I can able to provide some in resources available. For example, Liman Center for Wellbeing provides suicide gatekeeper training program for anybody, any volunteers, NGO, student, teacher, parents can. For
So they
example,
can contact Niman's Wellbeing.
Liman Center for Wellbeing, NCWB.
Okay, sir.
So, for example, if some organization want to get a training, specifically certain teachers, some certain developing, they can approach to, for example, Nimans launch another program for especially for institution for especially like adolescent children who are going for a PUC degree sort of that. That's a youth promotion program. It's a multi-site it's a project of Indian Council of Medical Research where people can reach out to that, including we are providing that 1 day training for the teacher as well as 1 or 2 days training for student as well as a youth champion. So there is a separate things what teachers can do and what sort of system they are able to develop in order to provide the services. Like as you mentioned, about student counselor things are there. So the counselor what can do, what are these things she or he can able to handle, and when they can able to connect back to the healthcare system like demands or other psychiatric services available across the state.
Okay, sir. Thank you.
And one more thing I would like to add at this moment, madam. So, National Medical Council, for example, for the undergraduate UG students now under the CBMA program, the mentorship program has been initiated. And initially, when the students comes, we have a foundation courses under the UG curriculum and also mentorship. So, mentorship, the student can choose either the faculty or his seniors or one of his buddy who can be helped not only in the academics as well as his personal issues and all those things. So such programs are even taking place even in engineering college and other colleges also. Even AICT has also made compulsory for technical education colleges also. And one more thing is even under the government of Karnataka. So even under the all the college teachers, each college there is a student counseling centers, and in all the universities, NIMANS itself has trained more than 1,000 teachers across Karnataka, especially these degree colleges, to identify any issue. Because in the adolescents, you know that one is substance use is the one which is rampantly using cannabis, alcohol, and all those things. Second one is relationship issues. Nowadays, relationship issues are popping up like anything. So those things have been addressed by these counselors, and or they can approach any helpline as Dr. Guru has pointed out.
Okay, sir. Thank you so much. Thank you. Sir, any posters are available? Any posters, any leaflets from maybe from the NIMAN's website or anything?
Yes, madam. Government of Karnataka has also issued under the Government of India National Health Mission. Many IEC materials are there. I will share with John. And also NIMANS has also made many IEC materials through Mental Health Education Department, as I remember. And those with that they can also if you go to the WHO website also, or World Suicide, if you Google World Suicide Prevention Day, there is an International Association for Suicide Prevention. Even there also you get a lot of IEC materials in local languages only, madam. In multiple languages you will get it.
Yes, sir, because the stigma is the main issue, and a lot of people, nobody wants to hear this word or say this word. Everybody wants to, like avoid it. So again, warning signs and all can be easily missed. So in the teachers, they have to look out for these warning symptoms in the colleges.
Yes.
So some posters or some talks, that might help.
Yes, ma'am.
Yeah, usually you can approach through IMA. You can make in local colleges. You can have this mental health awareness activities. Usually we are taking up on substance use disorders to these young students across schools and colleges, and especially through the Narcotics Bureau. That is the police department is there. No, they are also joined hand with us. So across Karnataka, many activities are going on. So let us begin through this IMA also. We can make a lot of school mental, and also we have a school mental health program where under the RBSK, Rashtriya Bala Swasthya Kishore program is there, RBSK. Under that also people go, then they identify and they send them to the nearest DMHP or Taluka Mental Health Program Officer.
Yeah. Okay, sir. Thank you, sir.
Any other queries?
No, sir.
Okay. So if there are no questions, thank you, Dr. Guru Gowda and Dr. Supriya Agade for a wonderful presentation. So over to Dr. Karnakar.
Thank you, madam. Thank you, sir.
Thank you so much. Any other comments from anybody? No comments. President, sir, are you there?
Yeah. Karnakar. Actually, everybody knows that what has happened previously and all, but anyhow, very good talk, definitely. So very, very impressive one. Hope ಎಲ್ಲಾನು ಎಷ್ಟು ಹೆಲ್ಪ್ ಆದ್ರೂ ಅಷ್ಟು we can do that. So ಈ ತಾನೇ ನೆನ್ನೆ ತಾನೇ ಒಬ್ಬ ಹುಡುಗ ನೀವು ಟಿವಿನಲ್ಲಿ ಬರ್ತಾ ಇತ್ತು, ಅವ್ರ ಅಮ್ಮ ಬೈಕ್ ಕೊಡ್ಸಿಲ್ಲ ಅಂದ್ರೆ ಸೂಸೈಡ್ ಮಾಡ್ಕೊಂಡ. Yesterday it has happened. I think ನೀವೆಲ್ಲ ನೋಡಿದಿರ್ಬೇಕು. Actually ಆ ಅಮ್ಮ 50,000 ಕಲೆಕ್ಟ್ ಮಾಡ್ಬಿಟ್ಟು ಅವ್ನು ಬೈಕ್ ಕೊಡ್ಸಕ್ಕೆ ರೆಡಿ ಮಾಡಿಟ್ಟಿತ್ತು, ಬಟ್ she has not informed him. ಈ ತರ very, very difficult, quite very complicated issue. ಇಂಡಿವಿಜುವಲ್ ಹೌ ದೇ ಫೀಲ್. ಕೆಲವರು ಒಂದು ವಿಷಯಕ್ಕೆ ಒಬ್ರು ಸೂಸೈಡ್ ಮಾಡ್ಕೊಂಡ್ರೆ ಇನ್ನೊಬ್ರು ದೇ ಆರ್ ಏಬಲ್ ಟು ಟಾಲರೇಟ್ ಎವ್ರಿಥಿಂಗ್. ಆ ತರ ಆಗಿದೆ ಸಿಚುಯೇಷನ್. ವೆರಿ, ವೆರಿ ಕಾಂಪ್ಲಿಕೇಟೆಡ್ ಇಶ್ಯೂ. ಎನಿಹೋ, ಸೊ ಐ ಹ್ಯಾವ್ ಟು ಸಲ್ಯೂಟ್ ಅವರ್ ಸೈಕ್ಯಾಟ್ರಿಸ್ಟ್, ದೋಸ್ ಹೂ ಆರ್ ರಿಯಲಿ, ಅವ್ರಿಗಿರೋ ಸ್ಟಾಮಿನಾ, ಅವ್ರಿಗಿರೋ ಎಫರ್ಟ್, ಅವ್ರಿಗಿರೋ ಪೇಷನ್ಸ್, ಇಟ್ಸ್ ವೆರಿ, ವೆರಿ ರಿಮಾರ್ಕಬಲ್, ಎಸ್ಪೆಷಲಿ. So definitely they are doing wonders, and definitely hope. So definitely we'll see good light, especially for this type of cases. And daily I'll hand over to our secretary for the vote of thanks. Thank you one and all for your good.
Karnakar sir, before just I would like to make one more comment. Whenever recently, as I told, Indian Penal Code Section 309 has been decriminalized, but now under the Mental Health Care Act Section 115, it is mandatory to send any patient who comes with an attempted suicide to any health professionals, whichever may be the specialty. In emergency department, whenever you are working, it's mandatory to send such person to the counseling. Maybe yourself you can do the counseling, or you can send it to the nearby psychologist or psychiatrist, whoever is available in and around your place, sir. So that has been made under Section 115 of the Mental Health Care Act. So I request all the health professionals to refer such cases, or you can counsel yourself, or you can tell them to use the Telemanasa helpline in that respect. And you need to document that, because tomorrow, did you refer, the court may ask. If because once committed, made an attempt, there is a high chance that the person has a tendency to make another attempt to prevent that. That is the issue, reason for that.
Yeah, very nice, very nice. I think it's much required. I think as like Mr. Shekhar highlighted properly, it's no more a criminal act. Of course, there is a concern about avoiding that. And we also pointed out necessary to refer this patient for counseling. I think it's very important actually. But we also know that there is a serious shortage of psychiatrists across the country. Actually, that's the issue of things to be looked at. So I request, now I take this opportunity to thank everyone who attended today's meeting. My sincere thanks to our President, Dr. Srinivas sir, Dr. Somsekhar Bijal, the President of the Psychiatry Association, the chief wonderful speakers, Dr. Dalanta Betul, all the people who are attending today, and the Ima Ksb. We express sincere thanks to each one of you. Thank you so much.
Thank you, sir. Thank you very much. And
Thanks. Good night.
thank you, sir. Good night to all. Thank you, Dr. Harisha, sir.
Thank you. Thank you very much. Thank you. Thank you, one and all. Thank you.
Good night.
Thank you, sir.